Welcome to Real Equity. This is your go-to podcast for all things related to the expanding world of asset tokenization. Here is a quick overview before we go live with today's show. The vast majority of wealth is stored in people's homes, and in the years to come, the majority of retirees will need to access that wealth. The reality is that options to access home equity tend to narrow the older you get. Reverse mortgages are highly inequitable, and selling a home brings huge disruption and costs. On top of this, there are many complexities and real-world economic realities from social to health to technology and to financial management that need to be considered. Join us now with John Kaplan, a partner at Boston Consulting Group and an expert on aging in place. We will unravel the complexities and celebrate the triumphs in the world of asset tokenization and how they can contribute to helping seniors age in place. Stay tuned and enjoy.
Hi, everyone, and welcome to the show. I want to thank our guest, John Kaplan, for participating in today's podcast. As our introduction stated, we are drawing on a genuine expert on an issue that impacts all of us. Everyone listening to this podcast has a loved one or a dear friend that is grappling with the very real issue of how to live out and finance their retirement years. An option that is becoming increasingly popular is aging in place. Like most options, there are pros and cons. John and his team from Boston Consulting Group have written extensively on this issue, and one paper they published, an aging in place strategy for the next generation, caught our eye. And we asked John to join us and talk about their research and his insights. John, welcome to the show.
Well, thank you for having me. It's great to meet you or see you guys in person, and I look forward to the conversation.
Perfect. We've got lots to cover, as you said, so let's jump right in with our first question. Could you start, John, by explaining the concept of aging in place and why it is becoming increasingly important in today's society?
Yeah, so Michael, first of all, your question's a great question, and it's a hard one to answer, as surprising as that might sound. Right. And the reason is because there are so many different elements when someone ages in place. There's a care element, there's the living element, there's the food element, and all these different pieces come together. And in many regards, especially for many people, certainly in the US and probably around the world, is that there are different players who will pay for that or who will try to motivate people to do different things against the different things. So the aging in place is probably most difficult because it crosses so many different lines or barriers that you have to include or introduce this concept to many different players who have many different agendas. I'm not sure it's perfectly clear in that, but the diversity of support for aging in place crosses multiple boundaries. And if we don't understand those boundaries, then we can't navigate it.
Yeah, it's a good point, because you're talking about, in many cases, the economic and financial aspects of this. So aging in place is not necessarily an inexpensive option, because if someone's going to age in place in their home and they need care, they need caregivers, they need help and stuff like that. So it's a significant decision that's how you're going to do it. It's not like going into an old age home, which has its costs, but everything is there. So it's fundamentally different. It's not a bespoke sort of service where you're getting someone to come into your home and take care of you, maybe sometimes even on a 24/7 basis.
And to build on your point, Michael, there are also incentives for the people who provide the care or the capabilities that they think about these things differently than the individual. So just take something very simple, okay? A physician would much prefer that the patients come to them than they go to the patient. It's much more efficient. It's much more convenient. So now we come to the question of, well, how many physicians want to round to multiple, do house calls like we did back in whatever, the 1970s and 1930s, whatever it was. And that's by definition, a less efficient model than walking around the floors of a hospital or walking around the rooms of a clinic. And so there are a lot of things that are below the surface that create this to be an undesirable outcome of allowing an individual to age in place. So again, there's many facets to this conversation.
Yeah. And that would also stand for nurses too.
Correct.
This would have to be mobile too. So, like, the whole concept of doctors on wheels or nurses on wheels, that's easy to say, but there's a lot of complication to something like that. And you're right, there is a lot of inefficiency for a medical system that's already strapped for resources.
Yeah, and again, I don't want to get ahead of ourselves, but there is a dimension of technology,
Yeah.
and that technology does facilitate being slightly remote from the direct caregiver. And again, I'm not suggesting that we computerize the entire system, but there are tools that can monitor and look for triggers or whatever else that happens that allow for the practitioner not to have to be right at the bedside. And again, we can take this way into science fiction and say,
Yeah.
well, we can replace people with artificial intelligence robots. Again,
Yeah.
I'm not of that mind yet, but I'm sure
Yeah.
somebody who's got a better mind than I do has already thought about that.
Yeah, we talk about that later in the podcast. That fascinates me, that part of it, because there are some technologies in place now that could be useful, and we'll get to that further down in the podcast because it's an interesting subject. How can technology help this process? Now,
Correct.
more from a wallets and wellness perspective, you've mentioned some significant issues here about costs and stuff like that. A lot of people say, can aging in place strategies be the financial saviors of senior care while elevating the standard of care? What's your opinion on that?
So my opinion changes between the short and the long term. In the short term, it is very effective and very efficient. And the reason in the short term it's so effective and efficient is because the cost of facilities are so high.
Mm-hmm.
And so if I can take care of a person in their home, and then I send a body to take care of them in their home, that cost is materially lower than taking care of them in an institution, a facility. And the facility costs are just so high that I can pay for, by avoiding a facility cost, I can pay for a lot of in-home care.
Yeah.
Over time, if we totally iron out the system and we stop having facilities being such a prominent part of it, then it gets back to what we were talking about before, Michael, which is that it is more efficient to take care of an individual as when it's a group of individuals, because the cost between individual A and B and C is much less. What people would call the windshield time or whatever. But the amount of travel time across the different people you take care of drops precipitously if they're all in the same institution or building or whatever that may be, as opposed to going to 12 different homes.
Yeah, and it's a good point too, because the older the retiree or senior becomes, the more medical attention they need, and the more visits they'll possibly need to have a doctor or nurse coming to them. So I get it. Maybe the solution is age in place to a certain point, and then at that point you need to go into a home. It's a very difficult paradigm to deal with, because obviously at the end of the day, people want their independence, right?
Yeah, without a doubt. And then lines are always very difficult to navigate.
Yeah.
And what I mean by lines is that so-and-so has got so many chronic conditions.
Yeah.
They have 3 chronic conditions and therefore they can stay at home. Now they have 4 chronic conditions and we say have to go into an institution. Or you say, whatever line you create, whether it be 3 chronic conditions to 4 or age 85 to 86, whatever line you create is extremely difficult to navigate. And it's true throughout all of healthcare. The best example of that is end of life, right?
Yeah.
We don't use hospice care very much as a society. And the reason we don't use hospice care very much as a society, or one of the reasons, is because it's basically saying that we've come to grips with the fact that the individual is probably never going to be healthy again, and that they're going to die.
Yeah.
I think the numbers, I don't have the numbers in front of me, but I think the numbers for hospice care on average are like certainly less than a week, and I think less than 2 days. And it's pretty easy to say that we know people are going to die more than 2 days in advance. So if we're on average, we're at 2 days or something, and again, my numbers may be wrong, but they're not dramatically wrong. It's where people who are deep into hospice would say the average should be like 6 months. That makes sense to me, right? You could see degradation, and it'll take probably 6 months for the individual to die. To sit there and say, well, we know this person's going to die. We know that 2 days before they die. It just feels like we could do a lot better job. But it comes back to my earlier point, which is that there are lines, and we all, as a society, struggle with lines. Like,
Yeah.
again, 3 chronic diseases to 4 chronic diseases, and I'm not advocating that's where the line should be, but that's a
Yeah.
line. 85 to 86, that's a line. And
Yeah.
we all know that an 85-year-old is not the same as another 85-year-old. And then, again, come to end of life, which is the perfect example of all this. That's a line where we say, oh, we're going to put you into hospice care. And as a result of that, we think you're going to die. We just crossed a line.
Yeah.
And we as a society struggle immensely with lines. And it's perhaps appropriately so. But lines are very, very difficult to cross.
They are, and they get even more difficult to cross with degenerative diseases like Alzheimer's, which in some cases can progress very quickly with some people, and in other cases with other people can progress extremely slow.
Yep.
Where does that line get crossed where they can't stay on their home in their home anymore because they're a risk to themselves, a risk to others? They need attention that they're not getting. There's also another aspect too of retiring at home, which we didn't touch on, is the social isolation.
Yes.
And that can be actually detrimental to some types of degenerative diseases like the Alzheimer's. Socializing is actually important. They need to socialize to keep their brain active, and social isolation can actually make it worse. So it's an interesting paradigm where you go, I want my independence and I want to live at home. But at the same time, the opposite is what they should be doing. They should be somewhere else, being and interacting with other people and getting the medical attention they need.
Yeah, and hidden behind all of this is, especially in the US, but it's true around the world, the healthcare system that we've built, the predominant portion of the healthcare system, the hospitalizations and so forth, is built around acute illness. And in our society, as of today, most people are not dying of acute illness, they're dying of chronic illness.
Yeah.
The ratios are disproportionately high to chronic illness. And if you go back to this aging in place concept, Michael, no one wants to die in a hospital. They would much prefer to die at home. They prefer not to die.
Yeah.
But if they're going to die and you said you have to die, and again, no one likes this conversation, would you rather die in an acute care hospital, which feels very sanitized, or would you rather die in the peacefulness of being in your home surrounded by your loved ones, et cetera, et cetera? And I know I'm sort of painting a better picture, but most people, not most people, I think almost all people would choose to die at home. And that goes back to this aging in place. And again, aging in place is not all about dying, but it's being able to say that if I age in the comforts that I've created for myself, I will probably do a lot better health-wise than if I age in a foreign location, which is a hospital bed, which is a bunch of people running around and bright lights and so forth, which is not the environment that I've created at home. Don't get me wrong, there's nothing here that's a panacea. And I think that's your point, Michael, which is that there are negatives about being isolated. Social isolation is not good, especially for most diseases, but for some especially. But there's lots of ways you can overcome that. Remember Papa Technologies, they were all about bringing college kids into the home to create a social environment for people who were aging in home, and that they could have something to look forward to that created a more social interaction, for lack of a better phrase.
Yeah, that's actually interesting, which sort of dovetails into the next thing. Is like, if I'm I'm in my 50s, I'm determined to, or even younger, I'm an independent-minded type person, and I want to age in place. So what are the personal financial planning that you recommend? Because there's housing costs, there's the inevitable health care costs, and other long-term care costs. How do you think people should approach it, and how should they plan for aging in place?
So as a society and as a system, we have tools that are there to help in that regard. By the way, I'm not saying they answer the problem, but excuse me, at one end of the system, we do have Medicaid. And Medicaid does pay for housing, does pay for food, and it does pay for healthcare. Okay. And most of the people that we all think about are not Medicaid eligible. They might be individuals, they might be subsidized, or they might be commercially insured, or they might be Medicare insured. And there's obviously different types of Medicare. All those players are dealing with the care side of it, and not the housing side of it. So there's the housing, there's the what are called activities of daily living, ADLs,
Yeah.
which are not paid for in most cases by insurance companies. Medicaid does pay for them, but as a rule, commercial Medicare, they do not pay for them. Private Medicare, Medicare Advantage, private Medicare does often pay for these things for certain patients, although the Medicare Advantage rates have been cut by CMS for going into 2025. And so therefore those benefits for Medicare Advantage that would have probably paid for some of these activities of daily living will probably be removed from Medicare because the benefits are being cut back because the rates are being cut back.
Yeah.
So as a rule, it goes back to your fundamental question, Michael, which is who's going to pay for it?
Yeah.
And when you come to sort of private duty home care, not the certified that's paid for by Medicare when you're recovering from a disease. You've gone to the hospital, you come out of the hospital, you now have a certified home care aide helping you. That is different than what is the people would call them. There's lots of names for them, personal care aides, whatever, that come in and help you with the activities of daily living. The only third party that pays for those personal care aides, as a rule, is Medicaid. Otherwise, it's self-pay.
Yeah.
And there's some exceptions where it's paid for by Medicare Advantage, private Medicare. But again, those exceptions I think are going to go away. So in that world, to your specific question, who pays for it? You do. Okay,
Yeah.
unless you're Medicaid eligible, you're going to do it, or you or your kids or whomever is going to pay for it. It's private pay, and that's not an inexpensive cost. If you have 8 hours a day or 24 hours a day of coverage, that becomes very expensive very quickly.
Do you have any idea of
Tens
cost?
or hundreds of thousands of dollars a year.
Tens to hundreds of thousands of dollars a year. Wow. That's a staggering amount of money, especially when you look at the, average North American. All the
Yep.
wealth is in their home. A lot of them don't have outside wealth outside what's tied up in their home. And this is
Right.
just a statistic that's well known. I think it's something like 95% of North Americans have all their wealth tied up in their home.
Yeah.
So they don't have a reservoir of cash sitting there. So that makes that difficult from that perspective, because if you're talking tens to hundreds of thousands of dollars, you can burn through that pretty quickly.
Well, if you just do simple math,
Yeah.
that a personal care aide they get $15 an hour, which is a very reasonable number.
Yeah.
That is over $30,000 a year.
Yeah.
That's for a 40-hour week.
Yeah.
Okay, they could easily do 3 times that if it's full care 24 hours a day.
Yeah.
So, and even there might be a shift differential. So right all of a sudden, that was 31.2 for 40 hours a week at $15 an hour for a full year. So now all of a sudden you multiply it times 3 shifts a day, and then if you have a shift differential, you're already into $100,000+.
Yeah. It's a significant
So it's an
amount.
astronomical number.
Yeah.
Now there are some plans where people can, in retirement and so forth, they can prepare for caregivers,
Yeah.
but it's small by comparison. And what I mean by small by comparison is because most people don't save hundreds of thousands of dollars for caregiving for end of life. Because as you said, most people have their money in their house, and they're, and houses are expensive, but they're typically not, multi-million dollar homes to pay
Yeah.
off $100,000 plus a year for personal care aides.
Yeah. The average home in the United States is just worth just south of 400,000 or in and around 400,000. So that's not a lot of money. You could burn through that money pretty quickly if you tapped into a reverse mortgage or anything else. That money would be gone pretty quickly.
The only, and it's only purely economics I'm saying, but if you look at the long-term care insurances that are out there, most of them, I'm trying to think of how to say this, most of them do not get used up. In other words, long-term care insurance gives you X number of days of coverage.
Yeah.
And most people don't live that long. that they use up their long-term care. So the majority of the people who are on long-term care insurance,
Yeah.
which again is probably more of an affluent group of people,
Yeah.
don't live to deplete the entire insurance benefit. So often when you're aging in place, you do age in place, but you often expire before
Yeah.
you consume all of your benefits. Or all, they people do not typically age in place and need a high level of care for 10, 20 years. That just doesn't happen.
Yeah, no, it's true. How much, give some perspective, how much is that insurance cost for someone who's, as part of their long-term planning? So, okay, I'm going to get insurance for this. I can afford it. What is the cost for something like that on an annual basis?
I should know the answer to this question. I don't, but I think, and I actually have it, so that's why I should know it.
Yeah.
But I think it's around $100,000 is what you put into it as far as the cost.
Okay.
And I think it gives you some multiple of that, make up a number of $400,000 of benefits.
Yeah.
But back to my earlier point, most people don't consume all the benefits, which is how the economics work out.
Yeah.
So all of us buy $100,000 and most of us use less than half of it. And so therefore that breaks, if all of us spend $100,000 and most of us use a quarter of it and the costs are $400,000 of benefits, I'm just making numbers up.
Yeah.
That is the purity of an insurance model.
Okay. Interesting. So that has to play in their long-term planning and the long-term economics. So shifting gears a little, and I'm never a big proponent of government's involvement in most things, but is there something government can do to help aging in place, make it more affordable? Is there something they could do, shifting policy around, removing bureaucracy, stupid rules? Is there anything out there that they can do that would be effective from your opinion as a professional?
Well, there's lots they can do. I mean, whether they have the fortitude to do that, whether that would pass across different elections and politics is probably too large a question for the two of us to answer.
Yeah.
But there are many levers they could press. At the end of the day, though, there's motivation not to press those levers because they drive cost.
Yeah.
And so if all of a sudden we said, the easy answer is let's have the U.S. government pay for personal care aids for everybody who's over the age of 95, just making that up, or for whatever they need.
Yeah.
Well, who's going to pay for it, right? Because you and I are going to pay for it in taxes because there's no other money to get. So, and you and I, not using us as people, but as a rule, taxpayers don't want to pay for that. So the government's between a rock and a hard place. As much as it might be a popular idea and so forth, the people who are making or voting are not going to vote for that. So that is something that the government can do. But again, extremely unlikely. I mean, there's a lot of benefits inside Medicaid that could be spread to Medicare and so forth that would never happen because it would just drive the cost of Medicare up higher, and no one wants to pay for that. There is a little bit of irony in this conversation, which is currently CMS is going after Medicare Advantage in a very aggressive way and trying to cut down its rates and cut down those who are risk-bearing primary care, cut the number of codes that they can use and so forth. There has been a growth of these type of capabilities over the last 10 years, we'll call it, from Medicare Advantage. That growth will stop or diminish because of the rate cuts that Medicare is receiving, Medicare Advantage, that private Medicare is getting from the U.S. government or from CMS. We aren't dissecting that problem and saying why it is or whether it's a good idea or a bad idea. The reason I bring it up is because there have been benefits that have come from private Medicare Advantage, that have gone in support of aging in place.
Okay.
Those benefits will be pulled back as the rates get pulled back. It's cause and effect. And I'm not advocating whether CMS should cut their rates or not. And it's a much more complicated conversation than what we're talking about. But when there's an abundance in Medicare Advantage, meaning abundance meaning that they're being paid a lot for their services or being paid handsomely for the services. I'm not saying they're being overpaid, but being paid handsomely, then they are restricted to how much profit they can make because that came out of the Accountable Care Act. So then what those companies do immediately is they pour those surpluses into more benefits to get more members.
Yeah.
That's being cut back right now. So there'll be less people, quote, going to Medicare Advantage, and there'll be less benefits going to pay for things like that would support aging in place. So in some regards, we're going backwards. I'm not suggesting that we're going backwards per se, but we're going backwards if you're against the specific agenda about aging in place. Because the only place you've seen it beyond Medicaid that I can think of offhand, maybe I'm missing something, but the only place you really can see it is obviously the private side, which sometimes get paid by long-term care insurance.
Yeah.
But the other side that gets paid, the next likely candidate is Medicare Advantage, and that's being pulled back.
Yeah, unfortunately, we live in a world of cuts, and those cuts impact people's lives, and particularly a demographic that's most vulnerable is an aging demographic, and we have a large demographic that's aging in North America and many Western countries, and it's going to be a significant problem. And there are health-related issues too, as we touched on. Dementia and Alzheimer's are skyrocketing, which puts an even greater burden on the system because in those cases, people do need care. Even if they're at home, they need full-time care. So it is a difficult situation.
And other societies outside of the U.S. put a greater reliance on the family.
Yeah.
And that, they're multi-generations live in a house and the family takes care of the family.
Yeah.
It's not quite as common. It may be common in certain ethnicities in the U.S., but as a rule, it's not as common in the U.S. as it is in European and Asian countries.
Yeah.
They take care of their own.
I've got that later in the pie, blue zones. Blue zones, there's more family orientation to taking care of your family. So there's everyone chips in, helps out. They remain part of that sort of family ecosystem much more intimately than they do in North America. And that makes a big difference to their longevity, also their happiness. So, and of course, diet and health play a factor into that as well.
Yeah, but there's also an element which is, again, this is getting way above my expertise, but there's also an appreciation in those societies, that a greater appreciation. Again, I'm painting with a very broad brush, so I apologize, but there's a greater appreciation for the elders in that society, the respect for the elders and the experiences of the elders, and there's a sense that the elders can bring experiences and insights to the youth of that generation to help them navigate and learn from it. And in our society, and again, this is too broad a brush, the elders there are exceptions to every rule, but the elders are typically not pushed aside, but there's part of our society that we want to take care of, or we really care a lot about. But at the same time, we don't have the same level of respect for their knowledge and insights and their sage advice that you might see in another society.
Yeah, I think as you become more of a tech-driven society, you get less reverence for the past because the past represents anti-technology, and the insights humans have are irrelevant in a society that's always forward-looking towards technology. And as you mentioned, AI, once AI comes full board and kicking in, are people going to consider, experience from 5 years ago completely irrelevant because AI says this? So yeah, I get that. It's a sad thing and a sad statement on society when there's little reference for experience and little reverence for people who have lived life and have experienced things that fundamentally are the same things you potentially are going to experience, and their insights can be very helpful. So hopefully there'll be a shift with that, which brings us to the technology end of this. Technology can be useful. I'm a big proponent of technology. Love what technology can do for people's lives, make them better. It's like everything, there are pros and cons. It's a weakness or a strength. It all depends how you apply it. Do you think there's technology out there, and do you think initiatives like the American Association of Retired People has what they call their innovation lab? And, that's an $8.3 trillion economy, the longevity, they call it the longevity economy. Do you think initiatives like that are going to help provide solutions, or do you think they're just a money-making grab to make money?
There's a lot of complexity to your question.
Yeah.
And so the word longevity, which everybody, not everybody, but most people want longevity. The fundamental question, at least behind longevity, is what am I willing to invest to get to longevity?
Yeah.
And I think the easiest way for me to explain that is at the age of 25, would you change your lifestyle to live from 85 to 100? And I think the answer is probably no, right? Because at the age of 25, you don't really have a clue what it means to be 85 or what a clue it means to be 100 or what those 15 years mean to you.
Yeah.
And you're pretty immediate gratification oriented at the age of 25. Changing your life expectancy those last 15 years from 85 to 100 is the exact opposite of immediate gratification. And most of our society is not willing to make the investments to live longer. And I know I'm painting again with a very broad brush, so again, apologies, but the point is that it takes discipline and rigor and all these other things to do the things that quote unquote will allow us to live a longer life. And as a society, we generally don't have a desire to do that.
Yeah.
Right. So we'd much rather have the extra helping of dessert than try and be trim and fit and be able to run another marathon. So the point being is that what we do in the age of 25 or 45, which may have material impact to how long we live, it's so far away. It's not in our field of vision. So when it comes to longevity, we as a society, and I'm talking specifically about Americans, are looking for that white knight that rides in and saves the day at the end. And that might be a drug, that might be some new invention, that might be an artificial limb or something like that, something that's going to, artificial knee, whatever, that's going to give me greater longevity, even though I destroyed my body or something at a much earlier age. And I think we as a society tend not to want to invest, as a rule, in our longevity. And that's where I get into some trouble with the concept that most things that we need to do at a younger age to get the results at a later age, we are unlikely to do.
No, it's true. See, what you just said is very true. Lack of discipline, eating that extra dessert, not once, but multiple times. Why we have an explosion of diabetes, type 2 diabetes. And
obesity.
They call Alzheimer's, even Alzheimer's, they're calling it type 3 diabetes. So we are inflicting on ourselves the problems of the future by not having some discipline in the present moment. And unfortunately, that's creating significant strains on the system, and will continue to get worse as the current population ages. And then you're right, it ties into, can you live at home? Well, no, you are obese, you've got type 2 diabetes, you've got congestive heart failure. You can't live at home. I know you saved a lot of money, Mr. So-and-so, but you can't live at home because you'll die in 2 weeks if you do. So.
But Michael, we shouldn't lose your point, or your question. Your question was around the role of technology.
Yeah.
And technology, at least in my mind, is an enabler. And you can get very science fiction oriented around this too, about what you can do with technology. But if I, as a clinician, whatever type, whether it be a nurse practitioner or a physician or whatever, can get a greater field of vision to more people because of technology.
Yeah.
Phenomenal, right? So I can only talk to, one person, I can only give care to one person at a time as a caregiver. Yeah. But if there's some sort of technology that allows me to monitor people and realize that, and it's a little bit of that spinning plates thing where you have 5 plates you're spinning, if they keep going back and forth to the different places to keep them spinning. Well, if all of a sudden I've got the technology and it says, hey, I've got a problem with individual number 3, so then I go over to individual number 3 and help to keep that plate spinning. And then that's going fine. And then all of a sudden I get technology tells me you got a problem with individual number 5. I go over there and keep that plate spinning. And in my analogy, the spinning of the plate is taking care of them, making sure they're eaten, whatever, bathing
Yeah.
them. So the point being, technology can be, or that they had an acute event. All those things can be helped through technology, that I don't have to stay next to you and keep my thumb on your pulse to understand what's going on with you. I can have technology doing that, and then the leverage becomes much larger. And
Yeah.
when the leverage becomes larger, the cost per unit comes down. And we may not agree that that's the right way to take care of people, but when you go to an ICU in a hospital, they're all monitored. There's a nursing station, and the nursing station, the people sitting at the nurse station are reading all the monitors. And by the
Yep.
way, the machines will set it off an alarm when one of the indications on the monitor, and that's monitoring. We do
Yep.
that in an ICU. We do that in a CCU. We could do that in a home, and I'm not suggesting that we create ICUs in the home, although you could take this to its logical extension. But I could monitor people in their home if I'm willing to rent the technology to do that, and therefore I could take care of people. Maybe I have a clinician who works that block,
Yeah.
and they just have in their car, they've got a computer that has 11 different screens that they give me the results on in 11 different people, and I just know which house to drive to
Yeah.
based on what it is. Again, I just made that up, but that concept is not, at least, foreign.
Yeah.
And then, to the earlier parts of yours and my discussion before we started having this discussion, that may be augmented by robots. Okay, and no one likes the idea of robots as caregivers, but if you see a lot of these science fiction movies, there's an argument that robots with some level of artificial intelligence are going to be there to help us to deliver hands-on care.
Yeah.
Not even go as far as solving some of the loneliness issues. Again,
Yeah.
I'm being very much, sci-fi oriented, but I
Well,
don't see that that's the end of the world.
the robots are probably a little in the distant, not too distant future, but there's a lot of tool sets now, like wearables, analytics, using current AI technology, cameras, sensors, telehealth. If there's a means by which they can quickly communicate with the person, all those things
Yep.
could solve some immediate problems. I mean, obviously, if someone gets to such a poor health level where they have to be in a hospital, but it could prolong that and reduce, as you mentioned, reduce the cost by leveraging current technology that exists. I mean, let's face it, an Apple Watch can give heart reading and blood pressure and a whole bunch of other health attributes, how they're sleeping, to a doctor, and they could be
Oh, yeah.
monitored and almost have a virtual ICU where they're being monitored on a regular basis. And the data coming in could be predictive, in the sense that maybe this person has had, several nights of poor sleep, they've been restless, heart rate's been up, blood pressure's up, they're red flagged. Let's give them a visit, a preemptive visit. So I agree with you. I don't think the robots are that far behind.
Well, there is a phenomenon that we're touching on right now, Michael, just to be direct about it, which is what we allow into the healthcare space
Yeah.
versus what we allow into other parts of our lives. So we talk about artificial intelligence and robots and so forth, and we kind of get nervous around it against the subject of healthcare,
Yeah.
because we don't want someone providing bad healthcare or whatever to us, and healthcare is so important. But that world we have entered already, where computers talk to computers for claims processing, where, I always use the example of Amazon, which says it's using artificial intelligence to tell me what I would like to buy or what I like to read or something.
Yeah.
And all it's doing is looking at things I read and what 100,000 other people read, and they say, here are the overlaps, and it's just using intelligence to determine those things. So the same things could be true for healthcare. Okay,
Yeah.
people who exhibit these 11 symptoms often have these type of diseases.
Yeah.
Okay, again, healthcare is something that's a little bit sacrosanct, and we're nervous about bringing that into that environment, but we use it in many, if not all, other aspects of our lives.
Yeah.
And we use it very comfortably.
Yeah.
And we may not like it, but we use it. And so we get more comfortable to the point that at some point in time, We don't like it when it's not there. So when you get on a phone, you have to sit on a phone and wait for 30 minutes to talk to somebody. You go, couldn't there have been like a chat bot here or something that could have made my life so I don't have to wait for 30 minutes? So we
Yeah.
begin and maybe healthcare is the last sort of vestige of not having that type of level of service. But I would argue that over time that will go away. So
Yeah.
instead of calling up to talk to the doctor and waiting for an hour to talk to the doctor or having them call you back, some tool, which might be part human and might be part technology driven, will help to answer my questions in a more timely manner, which
Yeah.
I will consider more higher level of service and perhaps more convenient.
Yeah. Yeah, no, it's true. I mean, there's so many things out there that could help people from that perspective, and collapse timeframes for getting help they need or advice they need, or
Yeah.
in some cases, alerting a physician that this person needs to come in either into the hospital or someone needs to go out there and check them out. Yeah.
Yeah.
I
That's the
definitely
triage process. Yeah.
Yeah.
Very often the triage process. Yeah.
I've definitely seen that happen. So pulling back a little away from the technology, are you seeing a preference in all the research you're doing? Like, are people holding up their hand and saying, "Yeah, I want to age in place. I don't want to go into an old folks home"? Is that preference out there that people are just saying, "No, I'm not going to be one of those"? We have the other problem too is we have such a negative view of assisted care living. Like you have the ugly hospital bed, the cold room.
Yeah.
You can't do anything. There's no activities. Everyone around you is depressed and dying. It's a viewpoint a lot of people have of assisted care living, when in reality it could be a lot nicer. But are you seeing a preference that people are just holding up their hands saying, "I'm never going to go there and I'm going to die in my home"?
Well, so I think there's a little bit of a definitional issue. So, and there's two parts that are in my head right now. One is who pays for it
Yeah.
and the level of affluence, and that's one element. And then the other is you can be in a continuous care retirement center, which has assisted living as one of the levels of care,
Yeah.
and I would consider that as aging in place. Okay, so aging in place doesn't need to be, to me, isn't necessarily defined by the house I grew up in or the house I raised my kids in. It just means it's not, to me, aging in place means I'm not going to an institution that's like a hospital or a skilled nursing facility. I'm staying it could be an alternative living facility,
Yeah.
but it's just staying where I live as opposed to going to a foreign institution where I'm going to be taken care of for some finite period of time. That's how I define aging in place. So it doesn't have to be a home. It just needs to be where I live, and where I live could be in an ALF or something like that. So
Yeah. That's interesting.
but it varies. It varies dramatically. Excuse me. It varies dramatically based on who pays for it.
Yeah.
Okay. So as I said earlier, Medicaid pays for living.
Yeah.
But you have to be poor to be eligible for Medicaid, and if you were once not poor, then you have to deplete yourself of all your assets and so forth. And Medicaid and the states are very sensitive to that. But you have to be poor to go live in a Medicaid facility. Now, I'm not suggesting that anybody wants to live in a Medicaid facility, but there is Medicaid as a payer who will pay for that.
Yeah.
But then the other thing is that a very popular, which is sort of at the other end of the spectrum, a very popular vehicle for all this is the CCRC, the Continuous Care Retirement Center, which is really more of a real estate play. But you buy into a CCRC, you buy a unit, and then in that unit you have an HOA or some a monthly fee, and in that monthly fee is medical costs. So that is a way, and if you buy into a CCRC and you enter as independent living, you can go from independent living to assisted living to nursing home living, all under the same payment structure. So you make up a number, you buy a unit for $500,000, which again is not cheap. That's why I say it's the other end of the spectrum.
Yeah.
In that $500,000, you have an agreement to how much you will sell it for. So you might buy it for $500 and it gets sold for $400, and then you get the 100th. It goes back to your heirs after you pass away.
Yeah.
It gets $400, and that $100,000 is capital that goes to the CCRC company, and then in your monthly fees, you're paying for medical care as well as food and and
Yeah.
heat and so forth, electricity. But you're paying for that in your cost. And what they all do as a rule is whether you live in independent, assisted, or nursing home, the costs to you are always the same. And the cushion that they have to make sure that happens is that back end of $100,000 that you are giving to them as far as of the capital asset.
So that's interesting. So you essentially, if you owned a home, you'd exit your home and you'd end
Correct.
up into this ecosystem,
Correct.
where you're going. It's nuts and bolts from your start of your living and aging in place to more the day you pass on.
Yes,
Essentially.
exactly. And I have had personally been involved with. I can immediately think of 4 people who have done that,
Yeah.
and every one of them liked it. Every one of them.
It's interesting because I mean we've got this sort of ties back into what we sort of do at Vest Equity. We've got a housing crisis. Everyone likes to call everything crisis in North America now, but you've got a lack of supply, right? And if people decide to age in their home and stay in their home, that decreases supply of homes into the
Sure.
marketplace. If they decide to exit and take this path, it could alleviate, given the size of the demographic that's currently aging, it could alleviate some of the housing issues. So it's an interesting concept to get people to go from their home into this sort of really what is essentially an end of life ecosystem, right? You're going to stay there until you pass on and have everything covered. But it still requires, I assume, a certain amount of personal wealth
Yeah.
to be able to do something like that. You mentioned 500,000. I don't know if that's mid tier, top tier. I assume they come in all different tiers in terms of quality and stuff like that. Who are some of the, best providers of that type of that care right now in the marketplace?
Well, so the majority of them are nonprofit, and a lot of
Okay.
them have some level of faith involved.
Okay.
But I am not an expert on CCRCs,
Yeah.
so I can't comment. I've seen them. I've seen a number of them. I've done a little work for them, but I just don't know the market. But
Yeah.
my observation is that the lion's share of the CCRCs are nonprofit, and again there's some element of faith or some element of, and I'm not saying that they're ethnically
Yeah.
divided by that, but there's often a faith-based component of that. But I don't know if that describes 80% of the market or that describes 40% of the market, but it's some significant number of the market.
So are there any for-profit similar type business models like that you'd consider to be really innovative that are tackling this, I want to age in place, I want my independence, I don't want to live in my home anymore, I want to be in an ecosystem. Is there anything in the private sector that does that?
Well, certainly Brookdale Senior Living is one of those,
Yeah.
and that's private.
Yeah.
It's public. It's a publicly traded company, but it's
Yeah.
private.
Yeah.
So there are companies like that. I'm not expert enough to. I just know
Yeah.
Brookdale. I know the people at Brookdale very well, and they're great. It's a great organization.
Yeah.
But I just don't know enough of the space to comment on of that 80% of the market is private and 20% is public or something like that.
Interesting.
But there
Yeah.
are players, and what we need to do is, if we have a loved one or a family member or a friend who there's lots of sources for this type of information. I just don't know it off the top of my head.
But again, it's building, Brookdale's a great company, and certainly has great resources at disposal. But there's still the issue of building these facilities as the population ages. And if you're taking resources away from building homes to building facilities like this, we're adding to what's already a supply problem in the housing market, which is driving affordability through the roof.
Yeah.
Who can afford to buy homes. So it's an interesting paradigm that we've gotten ourselves into in terms of having to deal with that. Let's just quickly shift gear and start talking about those people who decide to stay at home. Do you see a problem? I mean, I do, but you're the expert. We've already got a health services problem where we've got lack of nurses, lack of doctors. If people are starting to stay at home more, and as we talked about earlier, you're going to send people to their homes. How are we going to deal with that when hospitals are struggling with even having enough nurses at the hospitals to deal with those patient loads?
So, Michael, I'm not sure I fully understand the question. Are you saying, are we going to have enough caregivers to take care of people when they're in dispersed locations?
Yeah, how are we going to cope with this, right? So if suddenly there's a big surge in people aging in place and wanting to stay at their home, which requires visits to the home, we've already got a lack of care in hospitals. Many
Yeah.
hospitals are struggling with nurses, doctors. How are we even going to cope with people wanting to have care at home?
Well, so we can't wave our hands and say we don't have a labor crisis in
Yeah,
care delivery. And depending on who you talk to determines how large that crisis is. But we do have a labor crisis. Okay, we've had one for upwards of 5 years now,
yeah,
and no one has said it's going to get any better. Not to mention, to your earlier point, that the population is aging and there's more people who are going into the senior ranks than ever before. So there's a lot of things that get in that exacerbate this problem. So so we do have that. Now there are arguments that have been made by people who study this that one of the solutions for this will be some level of technology.
yeah,
Okay, so getting greater leverage models so that it's not one person to one person, that it becomes one person to five people, and technology enables that. That'll help. And there's always the argument for greater leverage where people are trying to extend, whether it be nurse practitioners or physicians or specialists, and even through like the ideas of telehealth, where instead of you seeing your primary care physician and then being referred to a specialist and then coming back to your primary care, while you're with the primary care, they can make the telehealth inquiry and get that question answered and not have another referral and so forth. So the operating model for healthcare and healthcare delivery is being adjusted as we have this conversation.
yeah,
How we'll get all of that is in with the goal of trying to get to better care that's more efficient.
yeah,
Whether you like that or not is the way the new model.
yeah,
That's that to be argued, but that's what it's trying to do because there is scarcity of people and resources.
yeah,
Most of the times, we as a society deal well with scarcity because we compensate them more or whatever, get more, or we introduce technologies that allow us to get greater leverage. So, am I saying I don't see it as a doomsday? To be very specific to your question, I think it's going to require us to be innovative and thoughtful, which I think is great. We as a society do great in those situations.
yeah. Necessity is the mother of all inventions, right? So
Yeah.
I think I agree with you from that perspective. But I guess as we move towards that sort of space or that sort of evolution, family are relied on heavily, and how does that impact in the broader sense the workforce as well? Because we saw in COVID a lot of mothers stepped out of the workforce to take care of family, kids were at home, make sure that worked, and things functioned normally within the family environment. Are we going to see that type of exit potentially with a large demographic aging of mothers and in many cases too fathers stepping aside and saying, I got to leave my job for the next 6 months, or I'm going to scale down the amount of time I'm spending at work to be able to take care of my parents? Are we going to start seeing that?
I obviously don't know the answer to that question. My gut feeling is no.
Okay.
And the reason my gut feeling is no is because we just generally don't see that in our society. I might see that more in another society in Asia or Europe, but I don't see that. It doesn't feel like the way Americans have historically dealt with it. As we dealt with COVID and teaching our kids at home and all that stuff, that was a very rough time for the whole world, but certainly for America, in
Yeah.
that people didn't enjoy that and they don't like being homeschooled, or a
Yeah.
large number of parents don't like to homeschool, and they view that was they would do everything in their power to avoid that situation again. And so if you change it from the kids that they have unconditional love for to the parents who they may have some conditional love for or whatever, but it's going to be a different situation as it, for how you deal with your kids, versus how you deal with your parents. And if I can afford it, and if I can find a way to supplement, the care, so I don't have to be there 24/7, or I don't have to move them into my house. I'm not suggesting any of those are good or bad. I'm just saying that we as a society have not, as a rule, embraced them. And
Yeah.
that's why I always turn overseas where other societies have embraced them much
Yeah.
more so than Americans have.
So from
So,
from yeah, no, it's a valid point. Different approach to dealing with aging and a different perspective on it, and the last, the issues of COVID saw some changes, but you're right, people reluctantly made those changes, and I do get the sentiment, don't want to go back to an environment like that ever again. And
yeah.
we're going to look to other solutions before we start saying, yeah, hey, I'm going to take or cut my work down by half and take care of my parents. I just don't see people doing that.
I agree.
Yeah, and other cultures, it's different because there's more reverence for the aged, but definitely not in North America or Western Europe, that's for sure. It's definitely not prevalent in those cultures. So from a financial perspective, what do you feel insurance products and financial services need to do to help people age in place better in terms of services and product offerings?
Well, I mentioned, lightly before about the whole issue about long-term care insurance, which has had its ups and its downs as a society, and it was taken off the market for a while because it was such an underwater product.
Yeah.
But it's now back on the market, and it's been designed in a different way, so it's less exposure for the insurance company. I believe the insurance companies are quite intelligent about what customers want. And I think if there's a market, then they will build a product for them. And we as a society haven't matured to the point that we want a lot of products for that. But I think if there's any desire for those type of products, the insurance companies will rapidly try and create solutions for that. And they do it candidly where they do well. The insurance companies do well against those needs in the society. So there isn't uniform desire, but as an aging in place is a very young idea in our society. But I think as it matures in our society and becomes more of a conversation, it would not surprise me if we had more insurance products around that. But I quickly come back to something I said earlier, which is that most of the insurance products that we know about from a healthcare perspective are paying for the care of the individual, which is very different than the aging piece. Now, don't get me wrong, when you're elder and you have lots of conditions, then it becomes very similar. It becomes part and parcel of the same thing. But most of the insurance we have is for an acute intervention. We fall down, we break our leg, we get that fixed. Most of the insurance we have is we're past and we're into the Medicare world when we get into the chronic diseases, where we have 6 chronic diseases, from COPD to CHF to kidney failure to diabetes, all those things going on. Those are all chronic diseases. They have acute flare-ups, but they're chronic diseases. And that's very different. And the best way I can think about it is if you are a diabetic, how often do you want to be in the hospital? Ideally, never.
Yeah.
Okay. But if you break your leg and you can't walk, you might want to be in the hospital for a day, to get your leg fixed. So there's just a very different mentality and a very different tool to help cure people, the role of the hospital versus the role in chronic care, where things like care in the home become much more important in chronic care. Because again, you could take care of the same person in 2 different ways. You could say, I want you to sit in the hospital for 30 days, or I want you to sit at home for 30 days. We're going to do the same thing to you in both cases, but most individuals would prefer to be sitting at home as opposed to the hospital for 30 days.
Yeah.
And it could be for the same exact ailment.
Yeah. Hospitals are no place to sit around and hang around for 30 days.
Yeah.
It's not good for the hospital either, to be honest with you.
Yeah. Hospitals don't want you there either for 30 days. But yes.
Yeah. And I'm sure no one wants to be in a hospital for 30 days. It's not a great scenario. So we've touched on, we've hinted on other cultures sort of handling and having more reverence for seniors and the aged. Are there any countries that stand out, or any sort of policies governments have anywhere in the world that you've seen come across in your research that you feel are like the benchmark that other countries should try and follow? Or is it something that is just simply a cultural issue and would require such significant changes to us as a culture to be able to adapt to what they're doing?
So the simple answer is it's a cultural issue,
Yeah.
and that different societies have different relationships with the different generations and how they coexist with each other and so forth.
Yeah.
I am quick to point out when it comes to healthcare and the healthcare system, where people will quickly point to the negatives of the U.S. healthcare system versus Canadian system versus the U.K. versus the whatever other system you want to choose. I am quick to say you choose your poison in the design of your healthcare system. And what I mean is there's no perfect healthcare system. They all have their strengths and their weaknesses.
Yeah.
Being an American, I'm very comfortable with the U.S. system, and I think it has a lot of great attributes. But one of its greatest negatives is how expensive it is.
Yeah.
But having done work around the world, I've seen lots of other systems, but I don't believe there is this great system out there that if only we embrace the system of Switzerland, or if only we embrace the system of Australia or Germany, we as a society would be better off, or Singapore. I don't think there's a better system out there. I think there are lots of other options, but they each have their sins and they each have their positives. And again, we as a society, you and I could argue whether we should choose these 3 sins and these 3 positives, or we should choose these 2 sins and these 4 positives.
Yeah.
We're not going to get consensus amongst a population to that. And that's why healthcare is so complicated and it's so difficult.
Yeah, no, you've hit it on the nail. That is so true. There is no perfect solution out there, and you're never going to get consensus. Some people are going to think that's a positive, and others are going to say, "No, I don't think that's a positive. I think that's a negative."
Yeah, yeah.
And,
And there are other models, and those other models have strengths as well as weaknesses, and we have implemented different models here that have strengths and weaknesses. But to your point, Michael, consensus is extremely difficult to attain.
Yeah, and it's seemingly getting more difficult.
Yes. Now it slips to politics, but yes, you're exactly right.
Yeah, everyone's polarized on every issue, even how to take care of our elder population. But when you brought up a really relevant point at the very beginning of this, is that are you prepared to give up some of the immediate gratification now so that you may live a longer, healthier life down the road? And that is something that hopefully we can convince society to do, because it makes sense. You live longer and you live a more healthy, longer life. And it is that sense of discipline, right? We have become increasingly undisciplined as a society over time, and have placed more of an emphasis on immediate gratification. Unfortunately, some parts of technology encourage that, which is unfortunate. As everything, there's good and bad to everything, and how you apply it could be strength or weakness. But I do think a lot of this does lie in people taking a better approach to their lifestyles, living a healthier life earlier on in their lives, so that they may live a better life in their older years. And hopefully we'll get there, because that would solve a lot of problems.
But there is the counter argument, right, which is called technology.
Yeah.
So technology can replace my knee with a knee that's almost as good, or my hip with a hip that's almost as good, because I abuse my hip or abuse my knee. You can go way further in that. And, the GLP-1s are helping people to lose weight that could never lose weight before. Okay. Yeah. And there are lots of arguments that by some very smart people who believe that eventually we will be able to live forever.
Oh,
okay,
I know.
Technology.
Have you ever read Longevity by Dr. David Sinclair?
Yep.
Yeah,
and
he researcher on longevity, and he says we're not too far away. Now he's probably being optimistic. We're not too far away from being able to pop the bill and reverse aging.
Yeah.
Now, how realistic that is.
But there are a lot of things in there. Another person who's been successful in predicting the future is Ray Kurzweil from Google now, but and he has said that we are probably a finite decades away from living forever.
Yeah.
and he's got a very good track record of predicting the future. He also says that pretty soon computers will be smarter than mankind,
Yep.
and that's not decades away, that's years away. So,
Yeah.
so all of a sudden, the world as we know it, where we were the smartest member of the kingdom. So there's a lot of science fiction that can come about that says we live forever, and then if you live forever, will you live forever as an 80-year-old, or will you live forever as a 20-year-old? So,
Yeah.
some weird things, and then again, so these are things that kind of go beyond my capabilities and thinking right now. So,
Yeah.
an entire world of 20-year-olds. So.
Yeah, entire world 20-year-olds. Although hopefully if they can reverse aging, they reverse your physiological age as well.
Yeah, yeah.
What a bummer that would be to live for eternity as a 90-year-old.
Yeah, exactly. So, these are the questions that need to be answered.
Yeah, it'd be a little depressing. And then I heard someone the other day said we are now almost at the end of what would be considered mankind, because we have just created a technology that will think for itself and have its own thoughts, which is not a human entity. It's actually artificial. And are going to have two parallel kinds moving forward. And will they be at odds with each other or support each other? So there's some interesting things that are definitely going to happen. And maybe 5 years we'll be having a different discussion, a different podcast about an entirely different subject matter. Everyone's living forever, and we're at war with AI.
Well, hopefully it's not 5 years. Hopefully it's at least 10 years. But yes.
At least 10 years in the future. Well, John, I want to thank you for some of these insights. They were great. You've definitely shed light on some of the major issues, and we've got we're going to list your contact information in the video summary. And so for those of you who want to reach out to John and his team at Boston Consulting Group, you'll be able to do that. I want to wish everyone a great week and thank everyone for watching our Real Equity podcast. Have a great day, everyone.